Hi, this is Dr. Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. Today, I have the great pleasure of inviting to the podcast two very good dear friends and colleagues here at Houston Methodist. First is Dr. Arthur Hsu, who is also in the Department of Obstetrics and Gynecology, National Taiwan University Hospital in Taipei, Taiwan. And Dr. Aparna Kamat, who is the Division Director in the Department of Obstetrics and Gynecology, Houston Methodist Hospital at Houston, Texas here. And Aparna leads our gynecologic oncology program. And today, again, very, very proud. And full disclosure, I'm also a co-author in this manuscript, but very proud of the work that they have done and recently published in Annals of Oncology of an original article titled GLP-1 receptor agonist use and cancer risk in obese non-diabetic adults. This is not only published in Annals of Oncology, but it's also going to be the lead article as well. So we're incredibly proud and also very happy to have both of you on the podcast and welcome and thank you for your time to discuss this manuscript.
Thank you so much, Pedro. It's really meaningful for me to be part of this.
And thanks, Pedro, for highlighting our work. I also want to thank you for all the support you've given us during the conception of this paper, as well as being a champion for our projects. So look forward to discussing our findings.
Excellent. So lots of questions. And of course, I also want to thank the fellows and the journal for submitting many of these questions. So Aparna, I'll start with you. Let's set the stage for our listeners. We know GLP-1 receptor agonists have become increasingly more popular for weight loss and managing diabetes. So what made you and the team decide to look specifically at how these drugs impact cancer risk in patients who are obese but do not have diabetes?
But thanks so much. So basically, we know that GLP-1 receptor agonists were initially developed for the treatment of type 2 diabetes. But we know that over the last several years, they have rapidly become the most widely used medications for management of obesity. So, there have been some studies recently that have looked at these drugs and cancer risk, but in type 2 diabetics and in obese patients. But what really was missing was like the evidence in the population that's actually the biggest users of GLP-1s. So this is worldwide. These are individuals who are obese, who are non-diabetic, and are using it for weight loss. And the important thing is this kind of segment of the population is very distinct. They're younger, they don't have as many comorbid conditions. So, we set out to try to ask a very specific question. Does this cancer protective effect of GLP-1 agonists extend to this specific group of patients, obese, non-diabetic patients who are using it for weight loss?
Excellent. And Aparna, I'll stay with you. At the next question, the article mentions that by 2050, a staggering 2/3 of adults in the United States are projected to be obese. So can you explain what obesity-associated cancers are and why this specific group of 13 malignancies is so deeply tied to body weight?
Yeah. We know that we are in the midst of an obesity pandemic, and not just in the United States, actually worldwide. Like you said, a staggering number of people within the US are going to be deemed officially obese. And so the International Agency for Research on Cancer has identified 13 different cancers, which are thought to be causally linked to having excess body fat. So these are called obesity-associated cancers. And these are not, these are cancers which we see routinely, colorectal cancer, breast cancer, endometrial, ovarian, pancreatic. So, there are 13 different malignancies which are, causally linked to having excessive body fat. And, the question is, how does this connection, what is this connection? So we know that obesity can drive many, many different biological mechanisms. It can cause chronic inflammation, it can cause insulin resistance, it can cause abnormal growth factor signaling, and all of these can potentially either cause carcinogenesis, promote it, or even worsen outcomes. So initially, when we started this project, we were thinking we're all GYN oncologists. So, it was, we thought we would do it. We would look at this in gynecologic cancer, so ovarian, and most importantly, endometrial cancer. But as we did more research, we found that these effects are pretty wide reaching. And so we then decided to look at the effects of GLP-1 agonists in the whole spectrum, and not just in men, but also not just in women, but also in men, so that then we can answer this question of, does GLP-1 agonists affect cancer risk at a population level?
Excellent. So, Arthur, I'll turn to you for this. And following on this topic, and actually this and other manuscripts, many have actually questioned, does GLP-1 actually have any anti-cancer effect itself? So, for the purposes of clarification, can you provide some comments to that?
Yeah, thank you, Pedro, for this interesting question. Well, some guess the impact of GLP-1 receptor agonists towards cancer is likely mediated through weight loss. With more weight loss, the less inflammation, or probably improvements in metabolic health. There is also preclinical evidence that these drugs may have direct biological effects, which may be linked with reduced cancer cell proliferation, increased apoptosis, or programmed cell death. That being said, our study was not designed to answer that biological question.
Excellent. Want to get a little bit into the study design, and perhaps this question for both of you. You utilize a statistical approach, a number of them, target trial emulation, propensity score matching, and inverse probability of treatment weighting. For non-statistics listening, what do these mean? And also interested in what database did you use and why?
Yeah, so let me start. So, when we have a question that is, affects such a large population, ideally, it would have been nice to do a prospective trial where we, kind of assign patients to either get GLP-1 versus diet and exercise, and then follow them over time to see which group develops cancers, and why. But in reality, this would have required, many years and an, impractical number of patients. So then we decided, well, let's look at this retrospectively. Let's look at this using a large real world cohort so that we can actually look at, a large number of patients in an efficient fashion. But we know that when we use when we do retrospective studies, when we use real world databases, there are a lot of limitations. So what we decided to do was use this strategy called target trial emulation. And what that is, in simple terms, basically, we design what we think would be the perfect clinical trial. And then we use those parameters and apply it to the real world database. So what does that mean? We define who is with the very strict eligibility criteria, strict start time, define the treatments. So that way, by doing this, we actually minimize some of the common, statistical errors like immortal time bias that you usually get with retrospective cohorts. And so then, Arthur, you want to talk a little bit about the other issues?
Yeah, thank you, Aparna and Pedro. So we used the Trinidx database, which includes electric health records from about 113 million patients across the United States. We chose it because it gives us the scale and diversity needed for the study. Because patients who receive GLP-1 medications are often very different from those who don't. We used two complementary methods to make the groups more comparable. One is propensity score matching. This is like creating a statistical twin for each patient on GLP-1 therapy by matching them with someone who had diet or exercise consultation, but had a very similar baseline health profile. This mimics the balance you would expect in a randomized trial. The other is inverse probability of treatment weighting. Instead of matching pairs, this method keeps the entire study population but assigns different weights to each person based on how likely they were to receive the treatment. This acts as an independent check to ensure the results are not dependent on one analytic method. In summary, we used a very large real-world data set, then applied modern causal inference techniques, target trial emulation, propensity score matching, IPTW, to approximate the rigor of a randomized trial as closely as possible within observational data. I really have to mention that the first time I heard anything about causal inference, it was through this IJGC podcast. It was Pedro and was our associate editor, Dr. Alex Melmed. They were talking about quasi-experimental designs used to answer questions that cannot be answered yet by RCT at the moment.
Excellent. Well, thank you, Arthur. And as a follow-up to that, this question comes from Alice Zampolini in Policlinico Gemelli in Rome, and she's asking, what are some of the key clinical baseline variables like smoking or family history that you had to adjust to ensure you were comparing apples to apples?
Yeah, thank you, Pedro. To ensure the groups were completely balanced, we adjusted for a comprehensive array of baseline variables measured in the 30 days before treatment started. These included demographics, socioeconomic and psychosocial circumstances, BMI categories, comorbidities, history of bariatric surgery, lifestyle factors, medication history, cancer screenings, documented genetic susceptibilities, and personal or family histories of cancer.
Excellent. So now let's get to the results so that then we can start discussing some of these results. So as you mentioned, obviously large database, large number of patients. I believe the cohort was just over 229,000 patients. So Aparna, what were the results of the study? How many patients did you have before and after matching? And what was the cancer risk reduction with GLP-1 receptor agonists compared to the control group?
Yeah, so this is a coming to the meat of the study. So the Trinidx database has medical health records from over 113 million adults all over the United States, right? So from those records, using very strict criteria like eligibility criteria, we identified a cohort of 229,467 patients. So out of these, 86,422 were GLP-1 receptor agonist users, and the rest, 143,045 were control patients. So these were patients who had been recommended diet or exercise counseling for their weight loss. After we did the propensity score matching, like Arthur said, matching close to, over 20 different variables among the two groups, we then came with a very well-balanced group of, two different groups, and each group had about 81,000 patients. So, these are very large groups of patients which are closely matched to mirror each other's risk factors. And so it allowed us to, like you said, compare apples to apples. And the goal of the study was to see what the cumulative decrease in the cumulative incidence of all obesity-associated cancers would be. And we found a staggering 41% reduction in the risk of developing an obesity-associated cancer among patients who got GLP-1 as compared to controls. And this represented a very significant hazard ratio of 0.59.
Excellent. So really impressive results. And I'd like to just get into some of those details. First question comes from Ana Conde at MD Anderson in Madrid. And she's asking, instead of comparing GLP-1 users to general non-users, your team intentionally chose a control group of patients who received dietary or exercise counseling. How does this specific choice help eliminate what epidemiologists call the healthy user bias?
Thanks, Anna, for an interesting question. Well, comparing drug users to general non-users or diet or exercise consultation introduces bias because patients who actively seek medical treatment or lifestyle interventions are usually fundamentally different, more health conscious, motivated, and engaged with healthcare systems than those who do nothing. By choosing a control group of patients who actively sought out and received diet or exercise consultation, we selected a comparator population with similar health-seeking behavior, medical motivation, and healthcare utilization, thereby neutralizing the healthy user bias.
Excellent. Now let's talk a little bit about the topic again of the types of patients. This question comes from Kudus Lawal, and I'll turn to Aparna. And his question is, your study notes that individuals taking GLP-1 strictly for obesity look very different demographically from those taking them for diabetes. So they tend to be younger, have fewer metabolic comorbidities. Why was it so critical to separate these two groups for this dedicated study?
That's a really insightful question. I think it's really critical to separate these two groups because, number one, diabetes by itself is a pretty significant, heavily confounding and independent risk factor for developing cancer, and we know that. And secondly, because patients who are GLP-1 users, they tend to be younger, they tend to have less comorbidities than those who are using it for glycemic control. And so they have different baseline risks for these cancers. So actually, if you look at our study, the median age of our population was actually 47. So this is much lower, much younger than most of the other studies that have looked at GLP-1 for diabetes. And you know that age itself is a risk factor for cancer. So the older you get, the more likely you get to get cancer and vice versa. So by separating these two separate populations and looking purely at younger non-diabetic cohort, I think what we did was we stripped away the biological noise of diabetes and its treatments, and we were able to evaluate the clean, direct relationship of GLP-1 use and the cancer risk in this group of patients, which is basically going to be the face of the future of, obesity management going forward.
Excellent. So this question actually for both of you, if possible, Chiara Innocenzi from Policlinico Gemelli, and she brings up a question that many of the reviewers also brought up. So perhaps, Arthur, you can start with this. She has a major caveat noted in your study is the 2-year median follow-up window. Can you let us know why the 2-year median follow-up? Why can't you do the study longer? And as a follow-up to that, she asked, for a clinician listening, does this mean a 2-year window is simply too short to see a benefit for these specific cancers, or is there a different biology at play? So Arthur, why 2 years?
Thanks, Chiara. So the 2-year median follow-up is really a function of real-world prescribing history rather than a methodological limitation. Although the first GLP-1 receptor agonist for weight control dates back to 2014, the formulation that brought widespread public attention, semaglutide, which is known as Wegovy, was only approved in 2021. More importantly, when we looked into prescribing trends using IQVIA data, which captures approximately 90% of US outpatient prescriptions, we saw that large-scale uptake specifically for obesity management did not meaningfully accelerate until mid-2023. Given that our data cutoff is June 2025, this means that the vast majority of patients using GLP-1 receptor agonists for weight loss simply do not yet have long-term follow-up available. As a result, the median follow-up naturally lands at about 2 years. It simply reflects how recent this exposure actually is. And Aparna?
Excellent.
Yes, I mean, I think, like you said, Pedro, this has been a question that a lot of people have brought up, and it's actually a question that we've also sort of mulled over. Why do we see this huge, decrease so soon, especially when we're looking at cancer prevention, and cancer typically has a long latency period. But what is striking is that it's not just the eventual risk reduction, but the early separation of the survival curves that we see even within those 2 years between the GLP-1 users and the control. So, what could be the basis for that? I definitely feel like the weight loss does play a huge role. There have been some studies even looking at bariatric surgery and looking to see patients who had surgical surgical, surgery for weight loss versus those who are non-users or not surgical patients, they showed a decrease in the risk of cancer in those patients. And those risks actually were seen within the first 2 years of their surgery. So losing weight can alter, insulin resistance, can alter some of the other, complex mechanisms that obesity triggers. So that's one, I think, definite reason for this, the effects we're seeing. But the second effect I do feel is that the GLP-1, like Arthur said, can interact directly with cancer cells. It can also interact with the tumor microenvironment, decreasing inflammation. It has been shown to work through the mTOR pathway. So there are many, many other biological mechanisms at play that we still don't know. And so I think these results definitely our call to researchers to look further into, why we're seeing these huge reductions.
Excellent. So, Aparna, stay with you. This next question comes from Camila David. She's from Budapest, but now here at Houston Methodist. We're all very proud to work with her as part of our research team. Her question is, when you looked at individual cancer types, some showed a dramatic drop, like multiple myeloma, pancreatic cancer, and endometrial cancer. So why do you think these specific organ sites were associated with such a pronounced benefit from a GLP-1 therapy?
So thanks, Camilla, for that question. So I think when we look at the results, I think what we're kind of seeing is actually the heterogeneity that is driven both in differences of how tightly some cancers are linked to metabolic and hormonal signaling, but also difference in the baseline incidence of certain cancers and the events that occur within that short period of time that we had. So some cancers, such as endometrial cancer, pancreatic cancer, multiple myeloma that you mentioned, are very, very intimately linked and are very metabolically sensitive. And so we see that when we alter their tumor microenvironment, when we alter their insulin resistance, we see some of these dramatic changes happening much sooner than other cancers. Now, other cancers such as, let's say, ovarian cancer or meningioma did not show much of a benefit. And that does not mean that there's no benefit. It just means that, number one, maybe the average age of our population was younger. There may be long latency periods for these cancers, or it may be that these cancers are not as hormonally sensitive or driven. So it doesn't mean really that there was no benefit. Maybe this benefit will show if we follow these patients longer. But I really want to kind of emphasize that the primary endpoint of our study was really not looking at these different sites. We were looking at the cumulative decrease in all cancers. And while this is great to look at, I think we need to look at it further before we say this is definitive.
Excellent. Arthur, I turn to you. This question is from Ezra Bilil, University Medical Center in Göttingen, Germany. And she's asking, your subgroup analysis showed a significant reduction in cancer risk among men, has a ratio of 0.32, compared to women, has a ratio of 0.65. You suggest in the manuscript that gastrointestinal side effects might play a role here. Can you elaborate on that?
Thank you, Ezra. So this is also an exploratory result, but we may have some explanation to this. While the biological reason for this gender-based difference requires further study, real-world data shows that there are more women on these medications than men. However, women report higher rates of GI adverse events when taking GLP-1 receptor agonists. This higher burden of side effects frequently leads to lower treatment persistence and higher discontinuation rates among women. Men may have experienced a more pronounced risk reduction simply because they tolerated the medication better, resulting in superior drug adherence and longer uninterrupted exposure.
Excellent. Aparna, I'll turn to you. Another interesting question. This one comes from Chiara Anio, who's now at the Mayo Clinic. She's asking, one of the most critical and sobering findings in your study was that Black patients did not experience a statistically significant reduction in cumulative cancer incidence, unlike white patients. What structural inequities or biological factors might explain this divergence in real world data?
Well, thanks, Kia, for I think this is a very, very important observation, but it needs to be interpreted with a lot of caution. Because I think what we are capturing is not really a biological absence of any effect of these drugs, but it's actually rather a complex interplay between social determinants of health, access to care, as well as some baseline risk differences among the Black population. So, what is interesting is that when you use real world databases, it actually is a mirror of society and healthcare in society, because what is put in it kind of reflects real world what's happening. And we know that in the United States, the Black population does have difficulty with access to care, delayed presentation, screening is lacking in this community. So I think some of this may mitigate or may attenuate some of the benefits that GLP-1s can have in this population. But also there is epidemiologic data to show that Black patients have a high preponderance of certain types of cancer. So colorectal cancers, pancreatic cancers tend to be more aggressive in this population as compared to others. And so that also may have an effect. But once again, these are study results that really, really beg looking into this further, and may be a great opportunity for policymakers to say, well, this even is one more reason why we need to make sure that even patients who need better screening and better access to care.
Excellent. Arthur, I turn to you because one of the most commonly asked questions often is, well, the type of GLP-1 receptor agonists matter. So this next question is, the apparent effect size of tirzepatide was substantially larger than that observed with semaglutide, despite you acknowledging that no head-to-head comparison was performed. Could this striking difference instead reflect calendar time bias, differential follow-up duration, channeling of healthier patients to newer therapies, or residual confounding rather than a true pharmacological superiority of tirzepatide?
Yeah. Well, we cannot claim tirzepatide is pharmacologically superior based on this data, because tirzepatide is a newer drug. Its users initially initiated therapy in much later calendar years. We did perform a matched year sensitivity analysis, which showed similar findings. Well, is there an explanation for this? We might have. Biologically, tirzepatide is a dual GLP-1 and GIP receptor coagonist, which might offer distinct metabolic efficacy. But again, the study was not designed to head-to-head compare these two drugs.
Excellent. I just have two more questions for you. I want to be respectful of your times. This question comes from Christina Kohler from Heidelberg University in Germany. And I'll ask you, Arthur. She asked, you found a 41% reduction for any obesity-associated cancer among GLP-1 users. Can you walk us through what this number means in practicality as we counsel patients, as we have discussions with patients as it pertains to a cancer risk?
Well, practically speaking, is the chance of getting obesity-associated cancers high? Well, not really. In this group of obese non-diabetic patients, which has a mean age of 47, the chance is 0.9% with diet or exercise consultation. However, for this 0.9%, we see an association of a 41% risk reduction with GLP-1 receptor agonist usage in cancer in 2-year follow-up. We look forward to longer follow-up of this data, but we do think in an era that obesity is pandemic, there deserves some attention that there is association of the drug usage with a reduction in obesity-associated cancers.
Excellent. So, last question, as is tradition now on the podcast, is formulated by AI after reading your article. So, Aparna, I'll turn to you. The question from AI was, finally, if these findings are successfully confirmed in long-term prospective trials, how do you see this shifting the conversation around GLP-1 drugs from being viewed primarily as a weight loss medication to a vital tool in preventing cancer?
So thanks, ChatGPT or Grok or Gemini, whichever one you used. So I think, if prospective long-term follow-up or prospective trials actually confirm causality, then I think it would meaningfully expand how we think of GLP-1 receptor agonists in clinical practice. We know that obesity-associated cancers now account for about 40% of all cancers in high-income nations, and actually they are rising rapidly in the under 50 age group. So if we do establish that GLP-1s actually do reduce cancer risk, I believe that they will no longer be pigeonholed as like a cosmetic or a weight management or metabolic tool, but they'll be thought of as disease modifying agents to prevent upstream cancer, to cause upstream cancer risk reduction. So what does that mean? Does that mean that you can take a pop-up pill and don't need diet or exercise? No, I think that what it will mean is that along with diet, along with risk modification, with exercise and healthy lifestyles, we now will have a pharmacologic tool that could metabolically change our cancer risk. And that is huge. As we have millions of people using these drugs worldwide, and as we have obesity-associated cancers being one of the fastest growing cancers, if we can have a drug that can actually alter the risk of developing cancer by changing your metabolic profile, I think that would be one of the biggest cancer prevention strategies that we will have seen in recent years.
Excellent. Well, I want to thank you both. This has been really an enjoyable conversation on in discussing all of these important questions. I know that you're doing further studies, including a prospective study with GLP-1s in patients with endometrial cancer. So a lot more exciting data to come. We're all really excited about this topic as we learn more and more, and particularly as it relates to gynecologic cancers. I want to congratulate you both. Again, excellent work through the entire duration of this project. A lot of time, effort dedicated. So congratulations to you both and the rest of the co-authors as well. There were so many collaborating for this study. And thank you for accepting our invitation to speak with us at IJGC.
Thank you so much for this opportunity, Pedro.
Thank you so much. I want to take this opportunity to thank Aparna for giving me this opportunity. This was really her idea. And thank you for teaching me all the stuff to guide me through the process, and to my friend who was doing this with me, Howard YC, Clary, Tommy, Paola, Suri, Linda, Neil, Camilla, Dilita. I really want to thank Methodist for giving me the opportunity for the education that gave me, and IJGC and the IJGC podcast and Pedro. This was IJGC and the podcast and Pedro was really my learning portal for gynae cancer. Thank you.